So here's our playbook for the explainer today. 1. Biliary anatomy and danger zones. 2. Gallstones types and origins. 3. Acute and chronic cholecystitis. 4. Advanced biliary complications. And 5. Common bile duct stones. Jumping right into section 1, biliary anatomy and danger zones. Because before you can understand what goes wrong, you absolutely have to understand the terrain. Okay, picture this. You're doing a simple physical exam and you feel an enlarged, palpable gallbladder. You've got to differentiate its cause instantly. A healthy gallbladder is pyriform, which basically means pear-shaped. If it's just distended, say due to a backup from a periampullary cancer, it keeps that smooth pear shape and actually has a bit of side-to-side mobility. But if that pear shape is completely lost and it feels like a rigid, fixed mass, that is a massive clinical red flag for gallbladder cancer.
Now, going a bit deeper, we hit the real surgical danger zones. Misidentifying anatomy here is, well, disastrous. And there's a classic trap you have to avoid: confusing the two triangles. The larger cholecystohepatic triangle is bounded by the inferior edge of the liver, the common hepatic duct, and the cystic duct. But right inside that is the true Calyx triangle, formed by the cystic artery, the cystic duct, and the common hepatic duct. Calyx triangle is absolutely critical because it hides the cystic artery and the cystic lymph node of Lund, which is actually the very first node to enlarge in gallbladder cancer. You have to nail this critical view perfectly before clipping any structures.
Beyond the triangles, the gallbladder has some, well, pretty wild quirks. For one, it completely lacks a submucosal layer. Its subserosal lymphatics drain straight into the liver, which unfortunately provides a direct highway for cancer metastasis. Then we have surgical traps like Moynihan's hump. This is a tortuous right hepatic artery that loops dangerously right into the dissection area, highly prone to catastrophic hemorrhage if you aren't paying close attention. And finally, the Phrygian cap. This is just a harmless anatomical fold that looks kind of like a French Revolution hat, totally normal variant, zero surgery required.
Moving on to section 2, gallstones, their types and their origins. Let's meet the invaders. So fun fact, not all gallstones are created equal. Breaking down the culprits, we've got cholesterol stones. These are usually large, solitary, and made up of over 90% cholesterol. Then we have pigment stones, which are super interesting. Brown pigment stones form an infected bile, a lot of times linked to parasites like Ascaris. Black pigment stones, on the other hand, are made of insoluble bilirubin and are massive telltale signs of hemolytic disorders like sickle cell anemia or G6PD deficiency. Interestingly enough, while pigment stones are the most common over in Asia, mixed stones, which are just a combo of cholesterol and pigment, are actually the most common type found globally.
But how do they actually form? It's kind of a specific recipe, which we can call the 3 pillars of gallstone formation. First up, lithogenic bile. This is bile that's literally super saturated with cholesterol, which you often see with obesity or after an ileal resection. Second is stasis, basically sluggish, non-moving bile. This happens a lot during pregnancy or from total parenteral nutrition, rapid weight loss after bariatric surgery, or even if the nerve to the gallbladder gets cut. And finally, nucleation. This is the actual spark, the initiation of the stone, which is usually kicked off by infections like cholangitis.
Now, if you're suspecting gallstones, whatever you do, don't just rely on a standard X-ray. Like 90% of gallstones are radiolucent, meaning they are completely invisible on an X-ray. It's the exact opposite of kidney stones. For gallstones, ultrasound is the undisputed gold standard, where they'll actually cast a distinct post-acoustic shadow. That rare 10% that are radiopaque, they might show up on an X-ray with these really distinct shapes, like the biradiate Siegel sign or the triradiate Mercedes-Benz sign.
So what if you just stumble upon these stones incidentally and the patient feels totally fine? Usually, we just leave them alone. But there are some really high-stakes exceptions where a preemptive strike is absolutely mandatory. If they have a porcelain gallbladder, which is a calcified wall carrying a high risk of malignancy, you operate. If they've got polyps combined with stones bigger than 2 centimeters, or if they're diabetic, you operate. Because for a diabetic, that first acute attack can be incredibly severe. We also step in for patients getting bariatric surgery, or folks who are Salmonella typhi carriers, or living in areas where gallbladder cancer is highly endemic. All right, let's step it up a notch on the escalation ladder. Section 3, acute and chronic cholecystitis. When someone rolls into the ER with right upper quadrant pain, your physical exam is everything. You've got to know these 2 classic signs. Murphy's sign isn't just basic tenderness. It's when you press the right hypochondrium, ask the patient to take a deep breath in, and as that inflamed gallbladder descends and hits your fingers, the patient sharply catches their breath in pain. Contrast that with Boas sign, which is hyperesthesia, basically extreme skin sensitivity, around the back right near the 12th rib. To actually grade how bad this inflammation is, the medical world relies on the Tokyo Consensus Guidelines. It's a really elegant, standardized playbook. Mild cases are your standard inflammation. Moderate cases escalate. Think a white blood cell count over 18,000, symptoms lasting more than 72 hours, a palpable lump, or signs of gangrene. But the absolute second the patient shows any sign of organ dysfunction, whether it's cardiovascular, neurological, or respiratory, bam, it is immediately classified as severe.
But wait, what if there literally aren't any stones? That's acute acalculous cholecystitis, a terrifying variant that strikes critically ill patients. We're talking ICU patients, severe burn victims, or folks on prolonged TPN. If a patient is just too unstable for surgery, we use a bailout procedure called a tube cholecystomy, just placing a drain directly into the gallbladder using ultrasound. And if a patient suffers multiple recurring attacks over time, they develop chronic cholecystitis. On ultrasound, you'll see the classic wall echo shadow or West sign. Histopathologically, you're looking for Rokitansky-Oshoff sinuses. If those rupture, they trigger a highly destructive condition called xanthogranulomatous cholecystitis.
Which brings us to Section 4, Advanced Biliary Complications. This is what happens when ignoring the playbook leads to catastrophic anatomical destruction. Let's quickly look at two major advanced pathologies. First, emphysematous cholecystitis. This is a deadly infection where gas actually forms inside the gallbladder wall. The primary culprit here is Clostridium species. It is highly aggressive and really common in diabetic or immunocompromised patients. On the flip side, we have a mucocele. This happens when a stone heavily impacts Hartmann's pouch, right at the neck of the gallbladder. Bile gets absorbed, and the gallbladder massively distends with its clear aseptic mucin. It's sterile at first, but if it gets infected, it rapidly turns into a gallbladder completely full of pus, which we call an empyema.
Okay, this next one is incredibly treacherous, Merizzi syndrome. Imagine a huge stone sitting stubbornly in the gallbladder pouch. Because of severe inflammation, it literally presses against the adjacent common bile duct from the outside, causing obstructive jaundice. Over time, that constant pressure necrosis burns a hole straight through, forming a fistula between the gallbladder and the CBD. It's diagnosed via an MRCP scan. Fixing it is wildly delicate. Surgeons usually have to do a partial cholecystectomy, leaving the stuck part behind, because if you rip it off, you'll tear the main bile duct wide open.
Now, imagine that stone burns a hole not into the bile duct, but straight into the bowel. That leads to gallstone ileus, which, by the way, is a massive misnomer because it's actually a dynamic, mechanical bowel obstruction. The stone erodes into the duodenum, travels down, and gets stuck. And here is a huge takeaway. It does not get stuck at the ileocecal junction. It gets stuck in the terminal 2 feet of the ileum. If it happens to get stuck way up high in the stomach outlet, we call it Bouveret syndrome. On a plain x-ray, you're looking for the legendary Wriggler's triad, pneumobilia, which is air in the biliary tree, features of a small bowel obstruction, and a radial pick shadow in the right iliac fossa right where the stone is lodged.
All right, the final battleground. Section 5, Common Bile Duct Stones, or choledocholithiasis. If a stone drops out of the gallbladder and blocks the main common bile duct, it stops the flow of bile from the entire liver. If that stagnant bile gets infected, you have cholangitis, which is a life-threatening emergency. You have to recognize Charcot's triad instantly: intermittent pain, intermittent fever, and intermittent jaundice, which fluctuates as the stone acts almost like a ball valve. If that infection spirals into full-blown sepsis, it becomes Reynolds pentad, adding severe shock and altered mental status to the mix. To definitively diagnose this, MRCP is your gold standard, though an endoscopic ultrasound is best if you're hunting for tiny microliths.
So how do we fix it? Well, the exact clinical management depends entirely on exactly when you find the stone. Scenario 1, detected before surgery. This is ideal. You go in with an endoscope and ERCP, cut the sphincter, pull the stone out, and then you just remove the gallbladder laparoscopically a few days later. Scenario 2, detected during surgery. The surgeon has to open the duct right then and there, a common bile duct exploration, remove the stones, and insert a T-tube for drainage using the Berhane technique. Scenario 3, detected after surgery. You attempt an ERCP, but if that stone is massive or deeply impacted, you have to escalate, literally cutting open the duodenum in a transduodenal sphincterotomy to go grab it under direct vision. Before we wrap, here are some absolutely crucial insider tips straight from the chief surgeon. If you ever have to make an incision into the common bile duct, it must always be longitudinal. never transverse, because a transverse cut heals into a stricture that'll permanently choke the duct. And never cut at 3 or 9 o'clock, because that's exactly where the fragile blood supply runs. Plus, when you're suturing the duct closed, you absolutely must use absorbable sutures, and the knots must be tied on the outside. If a permanent suture or knot is left inside that lumen, it's basically going to act as a nucleus, and a brand new stone will form right on top of it.
So, that brings us to the ultimate question. In a territory where literally a fraction of a millimeter means the difference between a routine recovery and a catastrophic biliary injury, how well do you know your surgical battlegrounds? The biliary tree is incredibly unforgiving, but with this playbook, you can absolutely navigate its dangers with precision. Thank you so much for joining me on this explainer today. Keep reviewing the material and never stop learning.